name is Sue. Welcome back to Holy Redeemer Childbirth Education Series. And today we are going to be talking about unexpected outcomes of labor. So one of the things that people don't anticipate and have absolutely no control over is whether they get high blood pressure when they're pregnant or they're in labor. So we'll screen your blood pressure every time you come to see your doctor at your prenatal visits. And occasionally we notice a trend of your blood pressure increasing. In addition, you may start to complain of swelling in your hands and feet. Most women who are pregnant have some degree of swelling in the hands and feet. However, with high blood pressure in pregnancy, the hands are extremely swollen, and the feet, you've now not able to wear your shoes. You're probably wearing flip-flops or larger size shoes. So that's our second clue between your high blood pressure and your swelling. Additionally, we also check your urine for something called protein, and occasionally we start to see that there is more protein in your urine as well. So if you have high blood pressure in pregnancy, the doctor will hopefully try to maintain your pregnancy, safely continue to have you pregnant, the baby continues to grow. If there's a point where the doctor is more concerned about you and the baby's growth and development, they may ask you to come to the hospital to be evaluated, and then possibly for us to continue to put you into labor with induction of labor. We use medication to induce your labor. We previously spoke about that in our variations of labor segment. And then we also may need to give you some medication to make sure that there are no complications of having high blood pressure in labor. And that medication is called magnesium sulfate. It does have side effects to it, but it also helps you not to have seizures if your blood pressure is elevated. Another unexpected outcome of labor is that sometimes your labor just doesn't progress, even with our medication to help your labor to be continued on, called Pitocin. Occasionally the doctor may decide that they need to break your bag of water because your bag of water hasn't broke on its own. So in this poster, you'll see the doctor's gloved hand is here, and then it looks like a stick that actually goes inside your body up to the bag of water. That stick is actually called an amnio hook. Let me show you what that looks like. It looks like, for many women who crochet or knit, a crochet needle. And at the very tip is a very sharp point. And this point is actually the part that snags the bag of water during that internal exam, and the doctor just gently moves this back and forth, and usually a small hole is placed in the bag of water. And then you'll feel a gush of fluid. And so typically, if you don't break your bag on its own, about halfway through your labor, the doctor may decide to use the amnio hook to do that for you. It also may help to stimulate your labor as well, too. You know, many times when you come to the hospital, we want to make sure that you and the baby are healthy and well. And so we listen to the baby's heart rate and count your contractions with monitors that we use that are placed and held onto your belly during labor. So they're called external monitors. One monitor will listen to the heart rate. It is an ultrasound, and it gets some gel placed on it, and we put that on your belly, and we can hear the baby's heart rate. Additionally, we also are able to count your contractions, and we have another monitor called the TOCO or tocodynamometer that sits at the top of your uterus called the fundus, and that helps us to capture your contractions as well as figure out how often they're coming and how long they're lasting, called frequency and duration. Occasionally, those monitors on the outside of the belly don't help us as much as we'd like to. We have some concerns about listening to the baby's heart rate or counting your contractions, and we're unable to do so with the external monitors. So we have here a sample of a fetal scalp electrode that the doctor can use to help us listen internally to the baby's heart rate. So the procedure is similar to breaking the bag of water, gloved hand with lubrication, 2 fingers into the vagina. The bag of water must be broken prior to using one of these. The doctor inserts the scalp electrode, and then, believe it or not, gives just a little twist. So this is ideally placed on the baby's head, if you can see real close, at the end of the fetal scalp electrode is literally one turn of a screw. And it would be synonymous in my day. The boys used to make the girls crazy by putting safety pins underneath the first layer of skin on their fingers. It didn't hurt them. And so that's the same type of a principle here. It goes under only the first layer of skin. They remove the guide, and then what's left is just a thin wire, a tiny little screw, only one turn. And then we have this little wire that hangs out of the vagina. The other end is attached to the baby's head, and we're able to listen much more accurately to the baby's heart rate and see how the baby's progressing with regards to your contractions. We also use another internal device to count contractions, and that's called an intrauterine pressure catheter. Same idea, lubricated fingers into the vagina. This device, however, goes around the baby's head and sits inside of the uterus to really understand the pressure or the force that the uterus is placing on the baby to try to exit the birth canal. So again, there are both internal monitors. They're not often used. We prefer to use the external, non-invasive option as opposed to the internal monitors. Occasionally, at the time of pushing, the baby, the mom is exhausted or the baby is not progressing further. The doctor may use something called a vacuum extractor. It's a small plastic cup that's extremely flexible. So again, with their gloved hand, they squeeze the cup, they put it on the baby's head, mom pushes, doctor gently guides the baby's head out of the birth canal. Extremely rarely are the use of forceps. They're almost never used. They look like big salad tongs. One's placed on one side of the baby's head, the other on the other side. They're brought together, and gently the baby's lifted out while the mom again pushes. So again, rarely used forceps, occasionally used vacuum extractor, and occasionally used internal monitoring as well. At the time of your delivery of your baby, the doctor may choose to do one of two things. If the baby needs even more room at the time of delivery, they may allow you to actually tear the skin between your vagina and your rectum. The path of least resistance is what the body chooses, and so there might be just a small little tiny tear. The doctor may repair it or may not repair it. If the baby needs more room or the tear has risk to go all the way to the rectum, the doctor may choose to do what's called an episiotomy, using scissors to cut very carefully at the edge of the bottom of your vagina into the perineum area. And that usually allows more room. If the doctor is going to use a vacuum extractor, they might need more room. They might choose to do an episiotomy versus allowing you to just tear on your own, which is called a laceration. Additionally, it's very, very rare, but I like to talk about it in my childbirth classes. Sometimes women actually have not just a short labor, they have such a fast labor that there's actually not enough time to get to the hospital. And they can deliver potentially en route to the hospital, or they actually never get to leave their home and they deliver in their home. This is called emergency delivery. Most first-time moms are at minimal risk for this to happen. This is something that could potentially happen, rarely does, for any mom who's second, third, fourth term. The more babies you've delivered, the more at risk you are to have a faster delivery. So what I'd like to just review for the emergency delivery is the most important things that you need to do. Most importantly, call for help. Call 911. Make sure somebody's on the way to assist. If you're by yourself, sit down or lay down. If there's somebody with you, have them call 911, and then they need to assist you to a laying down or sitting down position. And then the good news is for emergency deliveries, most of the time the baby knows their way out of the birth canal, and they do so quite easily, quite fast. We just need to make sure that the mom's in a position so that the baby doesn't drop or fall at the time of birth and is supported, as well. It's most important that you do not consider cutting the cord if you're at home, in a car, or en route to the hospital. Leave the placenta, the baby, and the umbilical cord all attached to each other. This helps to decrease the potential for bleeding out or infection. When you get to the hospital or the emergency crew gets there, they will take care of disconnecting the baby from the cord and the placenta. Lastly, I'd like to just reassure you, not every labor and every delivery goes the way that you plan. So just try to be as flexible as possible. Occasionally, our babies are born premature, and occasionally our babies are born quite sick. It's important for you to understand that we do have an intensive care nursery. We refer to it as the NICU Intensive Care Nursery, Neonatal Intensive Care Nursery. We have a level 3 neonatal intensive care nursery. We have over 20 beds to help care for the babies. We encourage the moms and the support people to go visit the baby in the intensive care nursery as soon as possible after delivery. If possible, we bring the baby to you to see the baby before we take the baby for special care. So we're fully equipped to deal with babies that are both healthy and well or require more attention and care here at Holy Redeemer. Lastly, I would like to talk about for this particular session is it's very rare to happen, but occasionally it does, where we go through our pregnancy and towards the end of pregnancy there's a loss. It's important for you to understand that we do have a grief support program here. We do have spiritual guidance from our chaplains, and we do have ongoing grief support after delivery as well too. Thank you so much for watching this segment, and please continue to watch others as well.